Let's get started. Join me in the pledge.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Okay, we have any public comment? We have our local people here every week. Good. Thank you for coming and sitting through the sessions with us.
We don't have to have the lights out.
It seems kind of dark.
It's real.
Do you mind if we turn the light on for you? Do that. Shed light on this place.
Yeah. You don't want to keep them in the dark.
So I should put,
Danielle,
Oh, yes, I guess so, since, thank you, Charlie.
Yeah, you're public.
Well, yes, technically I am. So it was brought to my attention by Jen Antle. She had a conversation with a gentleman, I think a gentleman from Christmas Valley, who was expressing, that rather than the North Lake EMS taxing district that's being proposed, he was suggesting that Lake Health District could provide EMS services to people in North Lake. And in communicating with me, Jen said that she didn't think that was feasible because of the laws surrounding CHA. Is that right? Critical Access Hospitals, CAH. So she was hoping that the board might address that either tonight or in some form to kind of just let people in North Lake know whether or not that is in fact a feasible option.
But isn't there something on the primary election going on right now for that?
Correct. So her concern was that this man and some other people have been discouraging people from voting for the taxing district and saying, rather than voting for this taxing district, we should just tell Lake Health District that we want them to provide the services. So that's kind of the concern.
I would suggest that if it's a ballot measure going forward, let Lake County, the people in North Lake County make their decision prior to anything that we might do. It's up to them to
Right.
determine what they want.
And I understand that. Jen's concern was that she is saying that Lake Health District would not be able to provide those services legally, and so she doesn't want people in North Lake to think that that's a viable option if it's not. But I understand what you're saying.
Actually, these services are mandated under the state, and it's the county that really provides the services.
Okay.
So it would be a county contract and would have to come through them.
Yeah.
So right now, we can't take a stance one way or the other.
And that's kind of what Charlie had said as well. Okay, thank you.
Okay?
I would also add that the question about whether we are capable, that the laws don't allow us, that isn't accurate. But this is not a choice that we want to weigh in on. This is absolutely something that the North Lake community needs to decide for themselves.
And my understanding is the county commissioners that set the ambulance service areas.
Correct.
So the county commissioners appoint providers for ambulance service areas. Those areas are already designated, I think by the state, or maybe it was recommended by the county a long time ago, and then the state approved them. So there are 4 ASAs in the county at present. We are responsible for providing EMS services in one of those ASAs. So whether we are doing this or not, it's not an issue of can we, by law, are we allowed to do that? As a critical access hospital, there's a great deal that we can provide. But that's not our choice.
Gotcha.
right now, it's up to the citizens of North Lake to vote
Yes,
next Tuesday.
and we wish them all the best in making the best choice.
Thank
Does
you.
that answer your question?
It does, thank you.
No other public comment? Approval of the consent agenda. Has everybody had a chance to read the minutes?
So move that we approve as presented. Second.
We moved and seconded to approve the consent agenda as presented. All those in favor?
Aye.
Passes unanimously. Okay. Looks like, Ed, you're up with the March 22 Lhd Finances.
All right.
I did.
All right, so this is the financial report for March 2022. It's
Want to use your clicker?
oh, that'd be awesome. Starting with patient count, you see acute is 345, an increase of 27 over the previous year. Clinics, 2,178, an increase of 56 over the previous year. Other outpatient services, 5615, a decrease of 242 over the previous year. Basically, that comes down to radiology had less and home health had a lot less. So it went from, say, 178 down to approximately 72 in home health, and then radiology had 87 less.
Are we still having COVID problem in home or in Lakeview Gardens about that?
I believe they're clear now, but it definitely was a big effect in March. And we had had OHOE bring in an infection preventionist, and she said we were using best practices. She went into the houses or the negative pressure rooms, being able to control spread of viruses was top notch.
There are still restrictions, so the state does have requirements. If we do have a patient that tests positive, we are limited in inviting new people to become residents. So that's a huge impact
For a period of time.
for a period of time, until that is cleared up. But we are still, that means we can't bring new people.
All right, overall for the month of March, had 8,051 visits, a decrease of 87 over the previous year. Everybody stems from radiology, home health, and that's just timing, I guess. Yeah. Okay, gross patient charges. For March, it was 4.3 million. It's a decrease of 159K over the previous March. It's still above budget, which is, I think we budgeted at 4.1 in gross charges. Next slide. Collections. Collections for March were 3.5 million, an increase over last March of 611,000. We're collecting.
There you go. Good. Yeah.
So, days cash on hand went to 89. There were, as you'll see in the later financials that we talked about, there were some large expenses. And I'll go into further detail later on. Still statewide exceptional, and pretty much nationwide for critical access. So. Perfect. All right, monthly net income. For March, we had 4.3 million in gross revenue, less the revenue deductions of 1.4 million, which is a little bit high. We're definitely drilling down on that. Less expenses of 3.7 million. I know it doesn't show it there, it's showing at 3.1, but that's because we have an add back of the provider relief fund, so that's why it looks a little screwy. And because basically we're subtracting 651,000 from the actual expense. So it resulted in a deficit of 205,000. Next one is for the year to date. Through March, total revenue was 27.2 million, less operating expenses of 30.6, and then plus the non-operating stuff that goes against the expense line results in a surplus of 3,019,000.
The contract labor services hit us hard.
Absolutely, and I actually did a slide for that so that we could kind of shine more light on that predicament. And then the other piece of that too is, in that big number, there were a couple one-offs that happen once a year, truthfully, it's like the audit or the cost report, you know. That's a big chunk of, you know, $30,000 at least in 1 month. Nothing exciting on the balance sheet other than, you know, obviously it's spent down in cash, but then we're also making a dent in AR, that's gone down to $1.1 million. So trying to get after it. Collections trend year over year. We're still up almost $4.7 million or $525 per month. So with the increase, it's still 18% ahead of last year. Here's the dashboard. All the arrows for the most part are going in the different directions, but we still have a few hiccups and you know, part of that is our little hiccups we're trying to work out with radiology and some of the different new lines of service that we're doing. They get stuck in the scrubber and we have to fix it. The team is working very hard to get through there.
Are you sure that didn't come off my medical chart?
Right?
It did.
My chart.
Oh, Jarvis.
That's what cardiology should tell me to do. Life goes up, life goes down. If it doesn't, you're flatline. Okay, so this is where I kind of try to dig into contract services a little. This is for the month of March. Acute is actually made up of the emergency room and the acute wing. Surgery is surgery and anesthesia. I actually broke those two out because they're larger numbers. Acute is 167K, so that's mostly, I want to say, traveling nurses, and to the best of my knowledge. And then the 118 and the ER is mostly from docs coverage, doctors coverage. Over in,
What is the ER?
oh, it actually rolled up into acute. So I was afraid if I broke it, I split it too much that people would know who works there and how much they make.
But I thought pharmacy was coming in-house now.
Yes, so that's one of the one-offs. That was a one-off contract that we owed that to
Amerisource Berkeley.
thank you.
But that was to clean up that agreement.
Yes.
So
We
we
paid their wages a month in arrears, and because we had transferred the contract as of April 1st, March 31st, this was that catch-up, which was all taken care of.
And then as far as radiology, what you don't see there in that 91,000 is that there's 115,000 revenue that and that cancels it out, I guess. So the hospital actually makes 15 to 25,000 on that transaction. As we go further down, cardiopulmonary sleep, that was traveling folks, respiratory tech and sleep tech.
So we're over budget by $1.7 million for the year. Do you see a correction coming in terms of traveling nurses or anything?
Can I address that?
Sure.
That might be helpful. American Hospital Association, Oregon Hospital Association, you will be getting some of the latest documents on what's happening in the country. Across the board, this is probably one of the most astounding time periods in American healthcare. The contract labor has caused most hospitals in the country, virtually all, to have unprecedented losses because of especially during COVID, when we had such an extraordinary difficult time finding workers. As it progressed, more and more people left their jobs to take these contract labor positions, and the costs are 2 and 3 times what would normally cost an organization. There's some recent indications that the contracts are going to drop off precipitously. Large part is for many of the hospitals, these costs were borne through federal dollars. so CARES relief dollars through this process. When technically the pandemic was deemed not to be an emergency in April, the contracts are dropping off very, very quickly. And more nurses are fighting, or not just nurses and other people that contract labor are finding that the contracts are being canceled. Other hospitals are talking about how they're going to have to curtail services because this is unquestionably unsustainable for the country.
One report you sent out showed something like, prior to the pandemic, 11% of payroll in hospitals was contract labor. And the last fall or whatever, it was something like almost 48% or something of the total payroll cost.
Some hospitals have experienced unprecedented changes where virtually the entire nursing staff quit and went to work for an agency and came right back to work. Or work for another hospital in the community. It's extraordinary experience. So is this something we are certainly facing the problem? How we address it is it's just frightening. But we're no different than any of the other hospitals. For the first time in Oregon, most of the hospitals had negative margins first quarter. There looks to be some change in April, so beginning of the second quarter. Some relief.
So on our contract with our provider, do we have a leverage now to negotiate the savings in those contracts?
Well, the article I sent out to you was hospitals just canceling the contracts and saying we're just not going to do it. There are provisos within those contracts. We don't have the ability to simply do them. The other part, of course, is we haven't been able to hire people for those positions. So it's easy to say we can't afford it, but we also have to continue to deliver service. So we don't hire people into these positions through a contract. If we didn't need them, it's not like we are trying desperately to just spend more money. If we can't find somebody, and in some cases we've simply had absolutely no applicants. And this is a very common experience in most other hospitals. So our solution is we have to deliver care, and we have to have that area covered. So we've got to use agencies. Can we try to curtail that? No, the key part is can we hire those? And that's what we've got to do. But you can see it is extraordinarily impactful. And
We can't sustain that.
it's unquestionably unsustainable. If we can't address that, we as an organization, and next week we have our budget meeting, we may have to discuss how we may have to curtail services because we have to maintain our viability as an organization. These are very difficult choices. So we're not taking this at all lying down or scoffing at it. It's very concerning. I wish I had a perfect answer. And if I did, I'd get called by a lot of hospitals for what.
Yeah, absolutely.
Sorry.
No, I think that was all I had for, except that to let everybody know that the budget meeting dates are, next Wednesday, May 18th at 5 p.m.
In this room.
in this room.
And if we don't get an approved budget, the following, is it following Wednesday?
Yeah, following Wednesday, May 25th.
Don, I have a question. You mentioned that we had no applicants.
Not in all positions,
No.
in some positions.
Do you know why?
Yes. We have a huge resignation among people who don't want to work. We have a lot of people that have found it easy not to work and sustain their lifestyle. This is a phenomenon that's occurring throughout the country. And
Or they're taking jobs as travelers to make more money.
They are
Done
doing
that.
that too,
They
yes.
have done that.
A combination of reasons, I'm sure.
But this is, we're not the only industry facing this. The construction industry is struggling with this. I can assure you, if you call up a specialist office and try to get an appointment, or half the time they can't get staff to do the work in the doctor's offices. It isn't just in the hospitals, it's everywhere. We think we have a great place for people to work. We have to keep working at trying to advise them of that, and we have to be fair. We think we're fair, but we can't sustain untenable rates.
Are we gonna be getting any information prior to the budget meeting, or we'll get a first look at it at the budget meeting?
We will do all that we can to get it to you as quickly before the budget meeting. We had meetings yesterday. Ed and Joey and I were working. Joey is trying some modeling of some different options. Some things are hopeful, some things are, we're trying to make our best guess and then work as hard as we can to try and make those best guesses come out. So our goal is to get it to you maybe by end of day Monday at the latest. So it gives you a chance to look at it. But
That'd be helpful.
we had hoped we would have it, you have to understand, we thought we would be able to have it to you this week. But when we see these kinds of numbers, we can't financially survive if it continues like this as an organization without making drastic changes. So we don't want to blow smoke, but we want to be as best and accurate as we can.
So you're on the hot seat.
Yep. First draft tossed my cookies immediately. So we had to go back and we really just want to make sure we're not making any mistakes. There wasn't a one-off cost, they were repeating again, that kind of thing, you know, it's, and that's all I have for the Lake Hill District.
Okay. You're still here with Moose Lake, but first, Commissioner James, did you have any public comment, or you just say to get bored?
Yeah,
Okay. Yeah,
just here to support this.
thank you. Okay. Moose Lake Medical Services.
All right, so this is the financial report for Lakeview Gardens. This one's a tough one.
Ouch.
Yes. You can see that contract labor line, and I didn't include that in the other, that was just hospital stuff. But you can see at 184,000, you know, it didn't even, I mean, we barely made the revenue for that, and if we're at like 40% occupancy, I mean, it's not sustainable for very long. So there was a couple things that we're working on to improve this overall. Because like if we have to close down one house because there's an infection, the other two houses, the long-term care, yes, they're a higher level of care, but can we take an admin, you know, in there until we get one to the house? It's just we're trying to think outside the box so that we can still be viable over there as well. And I think we're gonna make some big progress, and that has that bed tax there and the other expenses. So that's
And that's once a year,
no, once a quarter.
for a quarter.
Yeah, it's a big chunk of change.
I still do not understand the logic of that.
You have to talk to your legislators about that.
It's like that provider tax too, and the way that it flows. It's
Well, the provider tax makes a great deal of sense.
right, you get Medicaid.
So if you understand the concept, it doesn't hold true for long-term care. But we pay a provider tax. And what that does is, the way Medicaid is paid for in every state is it's a 2-to-1 match by the federal government. But it is only a match if the state taxes organizations. And what they have elected to do is to tax healthcare organizations. So they tax us, but because we're paid in a capitation, which means we take the total expense for the year divide it by 12, and we get 1/12 of that every month based on projected volume. It gets modified during the year, but that's what a capitation is. So while they charge us the tax, and they can prove to the federal government that they did taxes, they very quickly give us the money back and then continue to pay us.
But in this one, we don't get this back.
That's correct. It's, I wish we had what California has, or how they handle their long-term care taxing. And that is they pay.
Without that, we have pretty good.
Yeah.
We know it, but it's,
Yes, unquestionably. And so essentially what it's set, what the legislature has said is small communities, long-term care facilities are not economically viable. As such, that means that the only place that long-term care facilities should exist is in larger metropolitan areas. Well, for a rural state like ours, that's horrible.
The other issue is if we had more people that were Medicare and Medicaid in long-term care and assisted living, above what, 80%,
80% of our population, 80% of the patients have to be
then they
Medicaid.
would do away with the med tax.
Actually, it's 85%. We
85?
get 82 frequently. If we have a family member that wants to pay for the room, that reduces our percentage, and our numbers are very small.
this has been going on for years and years.
Oh, yeah.
30 years. We don't necessarily agree with it. No, we absolutely don't agree with it.
We brought it up to our legislators in the past, and it's, with our legislative clout, we don't get very far.
This is a state tax, right? Or to the federal
Yes.
state.
It is a state tax, because Medicaid for long-term care is paid for by the state, not by the federal government.
Okay.
All right. Last but not least, Lake Health Medical Supply, 41,610 in revenue, 33,000 in expense. Nothing too exciting going on there right now. They are working
At least it's a good number at the bottom.
Yes.
Mm-hmm.
to finish off with the win.
And we are making progress on some insurance contracts that should have significant impact on this, predominantly in the California market. We're making progress.
That's a huge thing, for sure. That's all I had.
Any other questions for Ed? Okay, we'll move on. EMS update. Tyson, how are you doing?
Good, good. I apologize for being late. I was in the middle of a project that I lost track of time. As you know, we got that grant from SAMHSA for substance abuse and mental health awareness, but in that grant, we wrapped in some new education equipment. Next slide. We took delivery of that last Friday. So now, with our old tools are there on the left, the stuff that we traded in, and then the Homotro tools that we purchased are there on the right. So as you can see, the old tools were quite a bit bulkier, required a lot more time to set up with the pumps and the hoses.
I remember having to adjust the vehicles to contain that.
Yep, and had a lot less, about a quarter of the max spreading force. So now we have another 13 inches worth of opening to be able to spread to open the doors with the jaws of life, and another 49,000 pounds worth of.
And they're a lot more portable.
And they are, because they're all battery operated, self-contained. They're a lot faster. They run a 2-stage internal pump, and you can feel there's a little spring-loaded click where you go from low speed to high speed. And as
Is it hard to manage?
no, actually, there's a couple pictures towards the end that almost everybody on the crew, including some folks from the disaster unit, made it out to the training on Saturday as well when we went out to the wrecking yard. And, I think we cut a couple of cars apart, flipped one over on its side, and stabilized it, because now each of our ambulances here in town have stabilization struts as well, so everything's gonna be a lot safer for our crews. Go ahead and go to the next one. Our cutters, which is the hydraulic cutters as well, as you can see, the old ones only had a little 4-inch opening. So when you had like those big, on the back of the cars that had like the 8-inch or 10-inch even C-posts towards that back window, you're making 3 or 4 cuts to get through that. With the new ones, we have a 7.2-inch opening, so it would be 3 or 4 cuts is maybe 1.5. To top it off, we used to only have, with the blade design, we only had about 39,000 pounds worth of cutting force to be able to cut through the metal. Doesn't really work well with boron and all that stuff that the newer car manufacturers decided to put in the pillars. Now we have 312,000 pounds worth of cutting force with our new stuff.
Will this cut through or work on virtually any vehicle that is manufactured?
Almost anything that comes out on the market these days, we should be able to get through.
Will we run the risk of Tesla being electrocuted?
Nope.
Or electric vehicle?
Nope, that's part of our training is where, so with Tesla, and I didn't put pictures in the slides, but they have went from traditionally when those hybrids and those electric cars first came out, they had the batteries were in the trunk or under the back seat. With the newer technology, particularly with Tesla, the battery is actually the majority of your floorboard on the bottom. And so we've just adjusted where we cut and where we push and pry and all that, so we don't run the risk of electrocution or anything like that with those newer cars. Let's go ahead and go to the next slide. Our hydraulic ram, we have one out in Adel. We didn't previously have one here in town for pushing. Our new ones, it comes with about it's about a foot and a half extension, and it's a 2-stage piston, so we can actually push the dash of the car. If we put it down in the door jamb, we can push that up to about 71 inches to be able to accommodate getting the fluffier folks out of the vehicles.
Fluffier?
Yeah, big guys.
Extremely well.
Yeah, husky. Husky would be another term. And with the rescue struts, we previously have only had rescue struts, and I'm not even 100% sure which brand we have on the rescue and out. Adel has the same ones that we have here in town on both 3472 and 3471. But they're quick, compact. We can lift a vehicle between the 2 struts in a matter of a 5-minute setup. So that'll come in pretty handy when it comes to vehicles on their side or on their tops, and particularly if there was a vehicle on top of somebody, we could set those 2 struts opposite each other with a ratchet strap or come along between them and lift that car up about that far to get them out from underneath the vehicle.
What are the number 3471?
So those are our 2 primary ambulances that are here in the station. 3471 is our backup. 3472 is the first one out the doors for any calls, and then 3474 is our transfer ambulance. So the next couple pictures are just some pictures of the training. There's what we call on the left-hand side is what they call a dirty side tieback. That would be for a car that's on its side. The rescue strut's there to stabilize it from rolling back onto its wheels. The straps are in place to prevent it from rolling over on us as we're working on cutting the roof off so that we can get the patients out. And then the come-along setup was an additional thing. Like if you had a car that got onto its side and say slid into a tree and crushed that patient compartment kind of wrapped around that tree, we can actually, with the stake that you can kind of see in that back tire, would be on the right-hand side by the yellow strap, almost where it comes together. Yeah, right there, Don. It's a 42-inch stake that's about, it's about 3/4 of an inch around. So you drive that through the tire, and with that come along, you can actually pivot that car off of that tree to make access to those patients easier. And that setup, I think we did that in about 8 minutes. So it's gonna really significantly help us in our extrication efforts. The right-hand picture there's Jerry Mello, one of our intermediates. I think she was working with the cutters there, cutting on the C post. So go to the next slide. And then the next, that's the right-hand side is also Jerry working with the spreaders. Or actually, no, I take that back. That's Mike Mathis working with the spreaders. And then with the training, we've developed new techniques over the past several years. Traditionally, we've always just popped the door open, kind of pushed down on the seat, slid that backboard underneath them. Well, that doesn't maintain stability or inline stability of their spine. So new techniques, we flop the roof off, stick that backboard down behind them, and then with a piece of nylon strap, you can actually, with 2 people on the patient and 1 on the backboard, in a matter of seconds, get that patient up and out and onto the hood of the trunk of the car, maintaining that inline position of their spine without wrenching on them a whole bunch. So that'll help, prevent any spinal cord injuries. That's all I got for you guys.
Excellent.
Thanks, Tyson.
Any questions for Tyson?
Have we used them yet? I mean, in real,
Not in real life. We will be using them next Wednesday. We're hosting an Operation Prom Night event for the school district. In fact, Paisley's even busing their juniors and seniors down to attend out at the rodeo grounds. So we'll have a simulation car accident to try to detour the kids as we go into prom and Memorial Day and graduation from distracted driving as well as, drinking and driving or driving under the influence of intoxicants.
That's next Saturday.
That's next Wednesday at 11 o'clock.
Thank you, sir. Medical staff update, Dr. Chang's not here.
So one of the things that we have been challenged with by Dr. Chang being voted in as the chair of our chief of the medical staff, is we have to make sure that his schedule matches when the board meetings are. We've tried to make sure that his schedule matches when the medical staff itself meets. But sometimes that's hard to do because of his schedule and those 2 days. So he's not able to be here today. But we have the 5 new and reappointment applications that I think we sent out to you. We hadn't. You didn't get to see them.
yes.
Garrett Powell was a CRNA as well as Barbara Brodero. Eric Stewart, Mark Bradbury, and Walter Buell all are reappointments as is part of their practicing clinicians. The recommendation of the medical staff is that you approve these applications. And I apologize that Dr. Chang can't be here.
Well, I so move that we approve these the medical staff.
Second. Okay, been moved and seconded to approve the medical staff update privileges as presented. All those in favor?
Aye.
Passes unanimously. All right. Tori, you're up. Nursing report.
Thank you. So, let's see, recently it's Nurses Week, so we've been celebrating our nurses and giving them a lot of love and attention, and thanks for their hard work. And we recently had, I think I've been telling you about students from Klamath Falls here, so we had 4 first-year students and 2 senior students. And the first-year students had an absolutely awesome experience here. They really got to see a lot. They got to go into surgery.
Are these RN students?
Yes, RN nursing students. So got to see a lot of different areas and get a lot of experiences that they wouldn't have been able to in Klamath Falls. And I think we met with them on their last day here and had a little luncheon for them, and they really appreciated how much attention they got here. And I think they got a real eye-opening experience into how much, as a new nurse, they could learn and how much we truly do here in this hospital with all sorts of different things that that they could be involved in. So we were real pleased with the outcome of that. I think our clinical instructors did an amazing job with them. It was hard to have 6 of them on the floor at the same time, but the staff really took them in and were engaged with them, so that was great. We have a CNA class starting in June, I believe, so we have interviews next week for that. I think we have 6 candidates
Right.
interviewing, so that's real good, all local folks. So there's that. And then since just transitioning into this new role, and that's been very smooth, Teresa's been very helpful in helping me move into my own arena and helping smooth that road for me. So some of the things I've been doing have just been focusing on committees and meetings in the department, trying to get some more staff engagement into some of those things, just to help us, make some better plans. For example, we've added one of our CNAs to our falls committee. So if a patient has a fall, we've got input from staff on the floor to help give us some insight to why things happen the way they do, and also some insight into how we can do better for our patients. So Kim started a Code Blue committee where she's managed to gather a lot of people from different departments, including the nursing area, to participate in that. So
Kim, who,
Kim McFall.
who's right behind?
Yep.
Just making sure everyone
Hi, Kim.
understood.
Hi, Kim.
What is a code blue?
What is a Code Blue? Or why?
What is Code Blue? Or is it a
Code Blue
committee?
is a patient whose heart to stop to stop breathing. But that just, it requires many more participants in the hospital than you would realize. So it's more than just a doctor and some nursing staff. So trying to get everybody engaged and all that. So those are the highlights from the nursing area, unless you have any questions for me.
Abigail is going somewhere next week.
Yes,
Can you
she's
tell us
going to-
where and what's happening there?
Yes, thanks for
Sorry?
bringing that up. She's going to Alabama to give a presentation to the Board of Certified Emergency Nurses to talk to them about what we do here in our program here, which, as you know, she's had a great deal of participation and coordination. And so she'll be giving her presentation next week, and that's a great way to show the rest of the country what we can offer here for nursing. So
Great, yeah.
Yeah.
Thank you.
yes,
And what place in Alabama?
is it
Huntsville.
Huntsville?
No, I don't know.
I was gonna say
Mobile.
Anniston.
Orange
Well,
Beach,
there you go.
I believe.
Oh, okay, thank you.
Where is it?
Orange Beach.
Orange Beach.
That's even better.
Yeah.
Good.
She'll do a great job, so
Yeah.
that'll be great
She will.
representation for us.
Make sure she comes back.
Trust me, I'm gonna put a tracker on her.
Okay. Thank you very much, Tori.
Yep.
And it's your turn,
Okay.
Rebecca.
So we have added 11 new staff in this last 30 days. So that's encouraging. So we're seeing a little bit of movement with people wanting to become permanent or start working again, I should say, and become permanent staff. Those areas that were affected by that were clinic, screener, greeter, revenue cycle, and dietary. We have actually 7 applicants for the NA class that starts in June, not 6. So that's encouraging to have those 7. We are holding a job fair in Strebe on June 8th from 4 to 7:30. We're going to feature EBS, dietary, and revenue cycle positions. We are, our region of HR directors are working with Troop for wage and benefit compensation survey to
Working with
see
who?
where I'm sorry,
You say working with who?
Troop. They're out of Portland, to look at wage and benefit compensation. It's a survey to see where our region of critical access or pioneer hospitals fit in with each other. And how competitive we are with the rest of the hospitals in the area. As you know, Wage Watch went away and salary.com is who we're working with. We're just getting started with that. I have just started the plans for, by the end of June, 1st of July, to have an HR dedicated Facebook page that will broadcast out jobs in another way. We already have 79 internet job boards that we work with, and of course a bevy of recruitment companies. But we feel like it's very important to have an HR Facebook page that also broadcasts, so it'll not just only hit people in the area, but hit people in Oregon and the Pacific Northwest. That will include Instagram, and I hope to get a Twitter up going too, and have some tweets out about our jobs. So those are some things that I'd done before at the other facility I was at, and they were helpful. So if people are looking for jobs, there should be many ways to find a job.
If you're gonna hit the Northwest, you might as well hit Alabama also.
Yes, absolutely. As I have said since I got here, I really feel it would be a good idea for us to try to have boots on the ground there in the South and trying to recruit. But of course, we have to get to a point where we can have HR staff, one of us rotate out and go down south and try and recruit. And we're too short-staffed right now.
It seems to me a lot of our traveling nurses come from the south, is that correct?
Almost all of them do, yes. So we have many people that come from Mississippi, Alabama, Florida, Georgia. So with the majority Mississippi and Alabama. So.
Being from Arkansas, I'm related to most people in Arkansas, so you might as well hit that.
Well, I'm from Missouri, so yeah.
But it's hard to keep them in the snow zone.
It is, that frightens them, it does. Okay, that's all I have.
Question for you, Rebecca.
Yes.
Approximately what % of the staff would work an 8 to 5 Monday through Friday shift?
Well, the majority of professional, non-clinical staff work that, and then there's support staff.
How many are we, or percentage-wise of our staff?
Oh, gosh, I'm gonna say probably 36%,
Okay.
just off the cuff.
Sure. Yep. Thank you.
Any other questions, comments? Okay, hearing none, we go to our CEO report. Mr. Twig.
First, thank you very much for allowing to have the meeting this Thursday instead of last Thursday. I don't think I would have been quite as coherent last week, so but thank you very much for making that adjustment. There have been a lot of things going on aside from just worrying about budgeting. There are several meetings that are coming up. I think we've sent notices to all of you about housing. Housing is going to be a bigger and bigger issue. There's some grants that are coming down about that. And they're going county by county. So if you have an opportunity, I know you certainly have interest. Please, if you can avail yourself. We will continue to bring you information about what some of these opportunities are. And they range from workforce housing to supportive housing to other, I can't think of all the different kinds. But there's a lot that hopefully will be happening so we can deal with a terrible challenge that we all face. Trying to recruit people to come here and they can't find a place to live, so they don't get a job. It is a frustrating experience.
Are these meetings open to the public or are they by invitation or?
Generally by invitation. Like we bring in people to help us understand what comes with the responsibility of a grant, how you deal with that, what are the rules and regulations that go into applying for and getting that grant. These are very preliminary. So we're not ready to say to the public, oh, this is the place we picked for this kind of service. It's hard to do what we do. So this is more to learn about what we need to do in preparation for it. And there are many entities trying to help deal with the housing challenges of rural areas. So please look for those, and if you can, that would be great. We have several building projects that we're working on, and many we've put out to bid, and we got little results. We did get some just recently, Adroit built Lakeview Gardens as well as our remodeled clinic has expressed willingness to come if they can do many of the projects sort of in a coordinated fashion.
Where they out of?
They're out of Medford. Now what's interesting is they will be here, they don't have quite yet dates, but harken back to when we were working on the clinic, we had trouble with our windows. And what we found when the windows were framed in and then they were placed, and before we actually put up the siding, we found that the windows were not sealing properly and that they were warping. So we contacted the manufacturer and we waited, if you may recall, for a long time before the siding got put up because we thought they were going to replace those windows and make it good. Adroit being responsible for the product that they're putting in, they struggled with this manufacturer. It's a large company, but it became a function of an M&A, merger and acquisition. It was acquired and now it's part of a large conglomerate. They have not been able to resolve the matter rather than take it to court. Have this continue to be a case. Adroit has decided that they will install windows that they purchase, that they choose, that they have good experience with. So they will be here to do that anyway. So that means they're going to take some of the siding off, take out the old window, put in the new window. So when they have a crew here, that will make it more interesting for them to do work on some of the projects that we have.
So what's the timing when they can be here?
They'll be here sometime this summer. I could say spring, but I'm not sure when spring's gonna be. I think we're gonna go from winter to summer like that. So I'm not sure. And we still may snow in July, so I don't know. But they're working on those dates. And so we're working with them. We're provided the projects and as an example, one of the projects that we talked about in the last meeting, there's a lot of work to do to remodel a building and getting it done to accommodate the grant requirements is going to be a tricky thing to do. We'll need the help to do that. When I talked about budget, you'll see that next week it is extraordinarily difficult. And we put together budgets here and all the time that I've been here. I used to think it was difficult. This is nothing like it. It just makes you start to try and figure out how do we make reasonable projections of what we think we can do. We are giving it as much thought as we can to be rational. And there's opportunities that we have, and we may have to make very difficult choices. So hopefully we'll have an adequate plan that you will accept it next, or the budget committee will accept it next week, so that we can have it properly approved at the June 2nd board meeting. We're in the middle of Oregon Nurses Association negotiations. We made some headway this past week. I was disappointed that we didn't get to the economics. So typically the way we negotiate these agreements is we talk about language and relationships between the nurses and the organization to make sure our agreement works well and is fair to both parties. Sometimes the language is minor and sometimes it's significant. We came up with some interesting suggestions on how to deal with staffing issues, and they seem to be very interested in that. Because we finished on Tuesday and did not get to the economic component, which is what kind of wages or changes to wages would occur, our next negotiating time period will be in July. So it will be post the
Why
contract.
so big a gap in time?
We had to find times that the Oregon Nurses Association representatives are available, as well as our attorneys are available. The attorneys, we have discovered, have had an explosion of work post this pandemic. And so everyone is busy doing a lot of labor issues, and mergers and acquisitions, and lots of things like that. That was the soonest we could make the dates. More to progress on that. I don't see this as antagonistic. We're just trying to looking for ways to make this workable solution. Yeah, Dr. Chiaco's Nuldi here. She goes by Chiaco. Her name is hard to say.
I ask how you pronounce it.
She goes by that first part, Chiaco. It's easy. Like trying to say my last name. And she will be coming now once a month for a week, working both the emergency room as well as the clinic. Part of the challenge that she's facing is her husband is still in a residency program in Washington, where she and her husband live. And the second challenge is that she has a toddler, or infant, I'm not sure how, less than a year or maybe a year. So finding help to deal with that. And so she originally thought she could commit to when Dr. Tan is here, she would cover the weeks that Dr. Tan is not. She got her 4th year residency in family practice in specializing in obstetrics. So she wanted to deliver as many babies as she could. We get 1 week, not 2 weeks a month. We're very excited about that. Dr. Chen, Jeff Chen, also comes from Washington. He had been coming once a month, and with the terribly untimely death of Dr. Foster, Dr. Chen has agreed to work 2 weeks of the month. So he's here 2 weeks on, 2 weeks on. It's a wonderful addition. As an internist, and he's finding that patients are very pleased to have him take care of them. So that's a really positive thing. Sorry to say that Rob Robbins, our Director of Nurses for Long-Term Care and Assisted Living, because of family issues, elected to return to Iowa. She had been anticipating she would be able to come back after a month or so. It appears that her family emergencies are going to cause her not to return. We have Mickey Golkin is the interim. We'll be talking with her about that role changing. Because Rob was able to get, I was able to get her approved as the administrator for the assisted living. Because I can't serve as that. I can be the administrator for the long-term care, but I cannot be the long-term care and assisted living and hospital. State won't allow me. So graciously, Ed has agreed to be the administrator for the assisted living. So he's busy taking the training and will have to pass the test to become a qualified administrator for the assisted living. So,
Thanks, Ed.
Oh, no, it's grateful for the opportunity.
in the interest of, as one of the board members said, could you make it really fast? I tried to talk fast and I will limit my comments unless you have other questions. Gerald, just saying.
I really appreciate you making the special effort to be here. Most would have been gone months, Charlie, so thank you for that.
I can't sit around and watch TV.
It's too depressing, isn't it? Okay.
Do you have any questions of me that I could address? Commissioner Williams, did you change your choice on asking any questions?
No, actually, one of the reasons, I'll just be straightforward, I was wanting to make sure I was here was, I know there's been a lot of talk about North Lake EMS on social media lately, and I had a feeling the question might come up. I understand the question's already been asked.
It's already,
It did at the
watch it
beginning of
on
the
tape, when you go home, this will be out on tape with the examiner.
Yeah, no, that's fine. I just wanted to be here in case anyone had any questions from our point of view and you know, how we saw it. Basically, from my understanding, the OARs would have to change in terms of definition on how they define satellite sites in order to accomplish appropriate billing. And all these things,
We're just gonna wait for the North Lake people to vote.
Correct.
It's up to them first,
correct,
and then
But
the county has the contract with the ASA.
it still comes back to us, and there's other things that we could do. I think there's just been a lot of talk about those things. And I just wanted to be able to be here to answer any questions if you have them. I think that's a great approach though, Don. Just let them figure that out.
Thank you, James. Yeah.
Yeah, thanks for coming.
Like, very welcome.
Didn't mean to put you to sleep there, so. Okay. With that, are there anything for an executive session?
There are a couple of items that we could address, and I'll be quick,
Okay.
or brief, it's better.
So we'll adjourn into executive session under ORS 192-660, bracket 2, bracket A personnel, bracket C medical staff, bracket G real estate, and bracket H legal. And we'll take 7 minutes.